Hi, it's Henry Shelford here. I'm with Professor Graham Hughes. I'm absolutely thrilled to be here with today. Hello, Graham.
Hello, thank you for asking me.
Well, thank you. It's great to have you here. And now the secret of the studio is also, so for everyone who knows, so we are actually in the same room. We're socially distanced, and that's why we've got two cameras, one on me, one on you, but we're otherwise looking at each other from a proper distance. To explain to everyone how we're set up. So I'm really excited to be doing this with you. Live Q&A on Facebook and Twitter and YouTube all at the same time. For those catching up, obviously it's going to be there for catch up. And if you're not able to stay for the whole thing, it will remain up there, and we're going to embed it on the website too. Now, Professor Graham Hughes is a man who needs no introduction, but that is not going to stop me. And I'm going to do one anyway. So, consultant rheumatologist, set up Europe's first dedicated lupus clinic, the Hammersmith Hospital. Yes. So that's the first ever, to give you an idea of the beginnings, really at the start. In 1983, you discovered antiphospholipid syndrome, which was later renamed in your honour as Hues syndrome. Which is, and we have done a little video on that. You can see on the website. You received the World Rheumatology (ILAR) Research Prize for the description of Hues syndrome. Yes. You're a member of the American Lupus Hall of Fame, a doctor honoris causa at the University of Marseille and Barcelona, yes. A master of the American College of Rheumatology, and founder and editor of the international journal Lupus. And as you and I both know, there's a lot of other things that could be on that list, but we'd be here for a long time. And I think it shows a very impressive amount and what you've done.
Thank you.
It's a huge honour. As you'd expect, we have had a lot of questions sent in, and so for people watching, you'll see me look right. I'm looking at the questions, we're going to be monitoring those coming in. We've had a lot sent in earlier. We'll start with some of those and then bring in some of the ones. So if you've got any questions, just post them into the comments. I need to do a disclaimer here. So to everyone watching, so disclaimer. Obviously, this is not a clinic. No personal advice can be given, and everyone needs obviously to speak to their specific doctor about anything that they think is of interest that could be useful to them. And the aim here is to provide you with the information, help you with that conversation. But obviously, no one's being seen in person. It can't be an individual clinic, and so no formal medical advice. With the questions, there was some overlap as you'd expect. So what we've tried to do is consolidate those. So if your specific question isn't read out, hopefully one similar is. We'll try and name check where there's no personal information. So if it's a question about the charity, if you posted a question more which has medical information in it, which obviously a lot do, then we're not name checking you, even if you publicly posted in Facebook. We're going to err on the side of caution there and not mention any names. And even if we do it for the charity questions, it's only a first name. But where there's medical information, we're not. We also, in terms of questions, we do plan to do more of these, Graham will no doubt confirm that we are keen to do more, yeah. And we're obviously keen to do them with him. So if your question isn't answered this time, then don't worry. Do ask it again, and it may also be that we're looking at some information to make sure that we've got it completely. But I think submit again. Amongst the questions, we also got some lovely comments, and I wanted to say one of many, frankly. Thank you. Thank you so much for the information. So this is someone posting, Graham. I really look forward to hearing Dr. Hughes speak on the 29th. He diagnosed me at the St. Thomas Lupus Clinic, which is, again, that's one of the things not on the list of things. You also set up the Lupus Clinic at St. Thomas Hospital. Yes. Diagnosed me at the Lupus Clinic many years ago now, and it had a profoundly positive impact on my life. And I found him to be a lovely man.
That's nice.
And I'm just saying thank you. And I thought that person spoke for a lot of people, saying how important the diagnosis is, so how important your discovery has been to many people. So obviously allows that diagnosis to even happen. In this case, you personally gave it, but also that you're just such a nice guy.
Thank you.
I think these are people just who've obviously been profoundly impacted. Right, I thought we'd start with some very general questions. So we've got some questions just about the charity, and I know we've spoken a bit about it in the past. We had a question from Sarah on Facebook. GHIC. No, this is a good. Now we've had this clarified before, just so for everyone. Is it GHIC or GHIC?
I think GHIC.
It's GHIC, so clear that one up for anyone. But GHIC has set out it wants to undertake research. What are the areas you're particularly keen to research?
The first thing is information. It's still under-recognised by many, especially when you're first diagnosed, you need help. And one of the first rules, I think, of our charity would be to increase knowledge. In terms of the research, that can be helped by specialist units, and in the UK, for instance, there are now specialist units in most major hospitals. My own particular interest over the years has been with the brain and in pregnancy, and the pregnancy clinic in lupus was one of the things we started back in Hammersmith days. The brain is interesting because so many patients during the course of lupus get, inverted commas, brain problems, and we still don't know why in some cases that's the case. And that's been a central part of my own investigations.
So particularly focus on the impact on the brain and on pregnancy.
Yeah.
And I think we're going to have some questions on it, but I think also part of your focus is trying to get more awareness around the impacts on pregnancy, so that tests happen earlier. Another general question, and then we're going to go into some more. The next section is going to be on COVID, which obviously this big discussion at the moment. I would like to know what you think could be done to raise awareness of APS, and what could be done to change the current guidelines of 3 miscarriages before testing commences on the NHS.
Yeah, well, it's a hobby horse of mine. One of the things we learned rapidly about the antiphospholipid syndrome was that it can affect the placenta in the pregnancy, and the baby doesn't get enough oxygen and the patient miscarriages. And it's now known to be the commonest treatable cause of recurrent miscarriage. So it's been a major impact on the world of obstetrics. But there are other causes of miscarriage, and the problem has been that, one of cost, I think, that it's been thought that really probably you need only to start doing tests for Hues syndrome after 3 miscarriages. And that's terrible in a way. Who would want to go on for 3 miscarriages? And what I've tried to recommend is a simple questionnaire, 3 questions, and that's on the booking in clinic of any woman for pregnancy by the midwife or the doctor. Number 1 is, are you a migraine sufferer? Number 2 is, have you ever had a miscarriage? And the 3rd is, do you have a family history? And by that I mean, is there anyone in your family, particularly female, who's got an autoimmune disease, thyroid, MS, lupus, for instance? And I think if you ask those 3 questions, I'm sure we will find that you'll have patients who are more at risk and should be tested after, say, 1 or even 2 miscarriages.
And talking to that point on awareness, one of the issues is the awareness both within the medical community, but also the wider population. So there are people having miscarriages who don't know that this test is available, and this is the could be the cause of them, and as you said, is the most likely cause.
It's a simple blood test. That's the other side of it.
And I think it's and as Graham has said, so this is an important thing for the charity and something that is a very, very strong focus. And to go back to Sarah's question, one of the things that the research, piece of research was discovering that it was the most prevalent cause of recurrent miscarriages, and these are the kinds of pieces of research that are very impactful and need to be done. So we're going to do some questions on COVID now. We've had quite a few people asking. With COVID, one of the symptoms has been clotting for people who have it in the severe form. So the question was, I'd like to know what Professor Hughes thinks about the possible link between COVID and Hues syndrome. Many people seem to test positive for Hues when they are very ill with COVID. I don't know if that statement is true. And have without controlled clotting. Could COVID be triggering Hues in people who are susceptible?
We don't know the answer to that. It's amazing, despite the thousands of people with COVID. And some things are definite, that there's a danger of clotting if you get COVID. And most major units, I've checked this out with all my colleagues, dealing with COVID wards, do have the patients on anticoagulants, for instance, heparin, to protect against this clotting. Whether this is through Hues syndrome or not, you won't believe this, but it's not yet known whether there's a link. We've known for many years that some viral infections can give you a transient positive test for Hues syndrome, and then that becomes negative. And it may be something like that's happening with the COVID. It's had a number of effects. Now, the good news is that a number of papers are now coming into the lupus journal from research centres. And if you have lupus, not Hues syndrome, but lupus specifically, you're not at increased risk from major problems with COVID. It seems that they do quite well, which raises the possibility that the lupus patients who are on treatment such as chloroquine, do better because it has an antiviral effect. But I think that's probably not quite straightforward. It's more complicated than that.
So I think that's a very important point that you've made. So at the moment, the research is suggesting that there's no worse income for people with Hues syndrome and having COVID. So but research is going on, and having spoken to some of the other trustees, I know that they are actively researching it as we speak, and I know that they're submitting papers to the Lupus Journal. And for those that don't know, the Lupus Journal is a very esteemed publication that breaks the latest research regarding lupus and Hues syndrome. And obviously, amongst many other things, you founded it. So, but it is very important. It's the way information gets distributed amongst the medical community and to be published.
Yes, we're seeing a run of shortish papers at the moment, but obviously big studies will take many more weeks.
Yeah, and I think that's an interesting. It's weeks, not months or years, which is the normal study length.
Because the numbers are so big, I think you can do this sort of study.
And so important. So. So some answers to the question, but some we're still waiting on to learn. Another question from Facebook: how can we be sure that COVID-19, that the vaccine will be safe for Hues patients?
All the tests for a vaccine go through a very strenuous safety thing. Obviously, the first part is the most dangerous, when you have to have volunteers to accept it to make sure that there's no very bizarre, unexpected problems. And most of the big studies have long since done that. So we know that there's been nothing unexpected so far. Then you go for the numbers business, and you have to do large numbers, depending on what the statisticians tell you, comparing normals and those with other illnesses and so on. So this methodology is been used for generations, really, for other vaccines.
And is Hues, so for instance, the flu vaccine and other vaccines,
Yes.
is there, because a vaccine on its own is not new science.
Yeah.
Is it normally recommended that people with Hues have vaccines or avoid vaccines?
Yes, in terms of Hues, most patients have no problem with, for instance, the common flu vaccine. There was a worry in lupus patients who tend to be allergic in many ways. Many lupus patients have a number of allergies that maybe vaccination should be thought twice. And I know a number of my patients have elected, those who don't have chest problems, for instance, have elected to go without. But most of the evidence shows that the vaccine is not a problem in the lupus or Hues syndrome.
Right. And one of the things I think that if you are in relatively good health and feel up to it, you can sign up to trials. So if you go to the .gov website, you'll find that there are places to sign up for trials
Yes.
for vaccines
Yes.
and for coronavirus. And actually, it's very important that Hues syndrome patients do that, because that population needs to be tested so that we know it's safe. So if you're
well, especially in view of the clotting that we've seen with a number of patients, absolutely.
And we as and the charity will post a link to those. And what will happen though is you're putting your name forward. It doesn't mean you're necessarily going to be part of the trial. They then evaluate you specifically as to whether or not it's safe for you to do it. But putting your name in the hat is a great idea, and certainly something that's recommended. Right. So we're going to now go into the more specific questions, specifically around Hues syndrome. We've obviously had a lot. Some have been quite specific with multiple particular things. So what we've tried to do is consolidate onto whether the central question is the same without going to people's specific results, so that we can have something that's more relevant for the wider group. Right, so I have primary APS. And actually, if let's stop the question there. What do they mean by primary APS?
Historically, we first discovered the syndrome in a lupus clinic. About 1 in 5 lupus patients have positive Hues antibodies. And it became the fashion to call those cases secondary, in other words, secondary to another disease like lupus. But after a while, it became clear that primary, inverted commas, primary Hues syndrome is by far the commonest. In fact, it's probably quite a common disease. And my own suspicion, and I stick by this, is that it will ultimately become commoner than lupus because of recognition.
And how common is lupus for people can have, and how common is people currently seeing
lupus? There are big differences. For instance, lupus, younger age group, all female, 9-to-1 female disease. Hues syndrome is another autoimmune disease, and they are all autoimmune diseases are all commoner in women than in men. So the patients with primary Hues syndrome, to answer your question, have got the sticky blood, have got the clots, have got the migraine, may have had a thrombosis. They're all, most of our patients are tested for lupus, and they will be negative for lupus tests. And on the whole, more than on the whole, those patients do not develop lupus at a later date, which is important to know.
Yeah. Okay, now moving on with that question, I have primary APS with mostly arterial clotting, even clotting whilst on blood thinning injections and aspirin. What other options are there? And we had a similar question. Hello, I am LA positive APS with no other health issues. My question is Warfarin the only medication I should be taking for APS? My primary doctor has mentioned other medication, but I'm very nervous.
Yeah, I understand that. The treatment so far has been almost 100% anticoagulants. That's like starting with aspirin, of course, but moving through to heparin and then warfarin, which is the thing that's hated by so many people.
And is that an escalating scale? So
it is,
aspirin,
and it depends
heparin.
on the severity of the patient.
Okay.
So if a patient's symptoms are maybe going a long haul flight and maybe getting a mild thrombosis, that patient may be on, say, warfarin for 6 months and then stopped. But you mentioned arteries, and this is one of the big things about Hughes syndrome. It can affect veins and arteries, which includes, of course, the strokes and heart attacks. And in those patients, obviously, your tendency is to go for warfarin. Now, warfarin, actually, in one way, is a very, very good medicine. Its problems are many in that it interacts with foods and drink and so on. So the patient has to have self-testing or testing under the anticoagulant clinic, which is a pain in the neck. But one of the commonest answers to that patient's query is that when you look at her warfarin little booklet that she gets, she's not getting enough. The dose is undertreated. And that's the first thing that you've got to be, or the doctor has got to be very astute to follow the patient's INR, which is international ratio of how thin the blood is compared with normal blood. So many patients run along, for instance, at 2, and many of those patients should be nearer 3. It's a matter of how dilute you can make the blood. So
what is the standard?
Standards, if you've had a little old lady with a heart murmur, will be on 2. In other words, you've got to be twice as thin as normal blood. In our syndrome, many of the patients need to be above 3. The blood has to be kept much thinner. Now that sounds pretty awesome, but it saves you from strokes, it saves you from heart attacks, and it's absolutely vital in those extreme patients to get it right.
And what's the downside of having that?
If you have an accident and so on, you bleed more. But all those drugs are the same. Take baby aspirin. If you take 1 a day, which many patients do, you bleed slightly more. In men, they shave, they cut themselves. They do bleed a little bit more, but it's not as common and as big a problem as people imagine. Anticoagulation, and hundreds of our patients are leading normal lives on warfarin. Are there any new treatments? There are, but it's at the moment a little bit disappointing. There are a number of new oral anticoagulants, tablets in other words, that work in a different way. Great excitement several years ago when they came in, but slightly disappointing in some patients. It doesn't seem to control the clotting as well. So although many of our patients, especially teenagers who don't like the idea of warfarin, are on these, but for the worst cases where there's big clots and major illness, I think they're not quite as effective.
And why do people choose to go on the alternatives?
Warfarin's got such a bad. It's very sad. Warfarin is called rat poison, of course, because we give it in mega doses to rats. They bleed. And that the media love that. Oh, this is rat poison you're going on. It's a fabulous drug when it works, because that patient, endless headaches, falling around, having seizures, all gone once the level of anticoagulation is right. So we have got an effective treatment, but it's such an interactive disease. If you eat a lot of greens, it pushes up the level of its toxicity or blood thinning. And so patients are given these large booklets on what to eat and what not to eat.
Okay, so it's
difficult.
It's very complex. There's some complex management,
complex management. And for instance, with your average bloke, who drinks a few beers at the weekend and doesn't in the week, that fluctuation is really a nuisance when you're on warfarin. So it's a drug where you have to be fairly precise and serious about treating it right.
Right. Great. Well, look, and I think that's very good. Now we had I said I tried to bring some things together. So this was I put as a follow-up. I'd like to ask whether there is a more known about other blood thinners that can be used instead of fenprocumine. This is because I now have lifelong blood thinners and I'm triple positive. Then the thrombosis service is unnecessary.
Triple positive is a cliche. It's when there are 3 tests for sticky blood. They all come under the bracket of APL, Apple as I call it, but APL is antiphospholipid. That's the blood test, and there are 3 ways of looking for that in most laboratories.
Okay.
And
so triple positive is
all 3 tests positive.
Right.
And
it doesn't make any difference. You have the syndrome. You don't have it 3 times over.
The people who've said, and it's partly true, that if you are positive for all 3, you're more likely to get clots even. So that cliche has stuck rather through the triple positivity. My own feeling is that any positive is probably worth watching like a hawk.
So you do, if someone's triple positive, you think they need slightly more attention? Yes. So what's fenprocumine?
It's one of the new anticoagulants. The coagulation, the clotting profile, is we all had to learn in med school, and I hated it. I really didn't understand. I think I missed the lecture on clotting proteins because there are factors, 1 through 10, etc., which take part.
No? Well, I think we're way past lectures for you. I think those were a while back.
Yeah.
I think you probably
these new drugs
more than many people know about.
Well, the people who know about the cascade, as it's called, of clotting, the drug firms have gone for some of those steps and able to block them out. So the whole family of drugs, anti-factor this, anti-factor that, are coming through. Variable results I mentioned a little bit earlier. Right. So this lady is on one of them, and I presume is reasonably happy and stable, so that's fine. It's just the worst ones where there have been major things like strokes, that there have been a few cases where on one of the new ones, they've got another stroke. So that's very worrying.
Right. And she says, I actually don't know if it's a she or he, the thrombosis service is unnecessary. What do they mean by that?
I don't know. I don't know what her meaning is there. I mean, the most thrombosis service, if you're on some, I think I do know. When you're on warfarin, there is a specific blood test. It's called the INR that tells you how thick or thin, and it's fabulous because then you can really control things over that patient. The new ones don't have that test.
And also hold that thought, because the next follow-up question is exactly about that. So, and this is a different person's question we've bundled together. I have been told to take warfarin for life, which but it is never in range and has to be tested every week. Are there any other options?
The answer is yes. It's a little bit difficult to answer specifically because we don't know what the patient's history was. For instance, did she have a new number of strokes or major heart attacks or other big arterial things? But yes, someone who like that is very, very sick will be on warfarin. And at the moment, you say for life, until something new comes along that's as good. Now, some patients, maybe this patient.
I think that's a very good point. Potentially, it's the best right now.
Right now.
Yeah. And new things are always coming.
Yeah.
Great. So the moment, other options are coming. But...
Yes. One thing I should say is a number of our patients, they go to the anticoagulant. Every hospital in the country has an anticoagulant clinic.
Perfect, yes.
And they go there and they have a sample of blood and the nurse takes it and they get a result on a printout. And it's, say, 2.1 today, it's 2.4 on another day and fluctuates. Okay. One of the things that my patients have found, if they can afford to buy one, is a self-testing kit. And that's absolutely fabulous as far as I can see. It is costly, it's a few £100, but it means you're your own boss. get a headache, or you start feeling dizzy, or your memory starts going quickly, immediate finger prick, shows you your blood tests. For some reason, the warfarin control has slipped, and you can monitor this. Now, many anticoagulant clinics are not keen on that. They think the patient shouldn't have, control of their own INR, but I disagree. I think if the patient or the clinic get together on this, it can be very helpful.
And you did earlier, you mentioned that anticoagulant clinics, which we were just talking about,
Yeah.
pain in the neck. What
Well,
do you mean by that?
some are super, but I know from
Obviously all the ones you've
we don't
been involved with.
no, I haven't, only peripherally, but they're now much more smooth. But in the old days, and not so old days actually, patients would queue up, go along there, and you wouldn't hear the results till the next day. And those cases were just, inexcusable in a way, and that's all been improved. I lecture once a year to the Nursing Society related to clotting, and you can tell by the feedback that they're very much on side with this one now.
And the importance for getting just for clarity, the importance of getting the result quickly, what does that do for the patient?
You can alter it. You can alter by 1 little milligram tablet, the warfarin, for instance, if you're on the low side. And do
you take that immediately?
Immediately, yeah. Yes. And in fact, again, it sounds fussy, but the patient's health is at risk. The patients who've done it, who've got it, just totally rely on it. Right?
And who have their one at home.
One at home. And they do it in collaboration with the anticoagulant clinic, just to make sure that there's no wide difference. Yeah.
Now you also in the last answer mentioned memory, which beautifully goes for the next question that was submitted.
Yes.
Can APS be the cause of memory problems if an MRI is clear?
Yes. And that's such an important question, because the MRI is wonderful. It's changed our lives. But yes, we see patients with sometimes quite marked memory problems who have a normal MRI. Why, I don't yet know. It may be a matter of degree. So we're waiting for some more sophisticated neurological screens, and they're coming along. I should say, I think that memory loss is next to headache as the commonest feature of Hues syndrome. And it can be very mild, but it can be so severe that the patient thinks she's developing Alzheimer's. And it's very interesting when you start listening to the patient telling you about their history. For instance, at the end, patients have this or that. You say, what about memory? And it all comes pouring out. One patient I always quote, who couldn't remember which exit of the roundabout to take when she was taking her children to school, and or I'm the joke of the family, I can't remember names, or it's very severe sometimes, and untreated, it can be really incurable. But luckily, it's very interesting. We think it's due to sludging of the blood, because the minute you give a blood thinner, and heparin is the one I haven't mentioned yet, but it's the fastest. It's given when someone gets a clot. Memory gets better. And we, for a while, about 10 years ago at St Thomas's, we had a young neuropsychiatric registrar working in our unit from the psychiatry department. And we treated patients with memory problems in Hues syndrome with heparin for 2 weeks to see what happened. And this girl couldn't find words. On a word finding scale, she was down in the 20% range. 2 weeks later, 80 to 90%. And our professor of psychiatry said no psychiatric drug gets near that sort of figure. So memory, if you go into it, is commonly affected.
And I can see now. When you mentioned earlier also that when people are being able to see their own blood levels, but also one of the things that might trigger them to go and check them is that they have their memory they notice their memory.
Yes. They say the cloud has come down. That's the commonest thing of it. But it's a real phenomenon. It's some people won't talk about it, but it mostly comes out.
And how does that impact with age? So as we age, our memory becomes less able
Yes.
as well.
We haven't done specific data on that, but I'm sure that's going to be a factor. I'm sure it is. But all ages get Hughes syndrome, and that can be a feature.
Yeah. I was thinking about that. If you have less memory capacity, then you notice any erosion much more.
I'm sure that's true, actually. The memory is something that really is major. I mean, I've often said that the brain is the most sensitive organ to sticky blood. And what's interesting is some patients, you do see changes on the MRI with little dots, and they improve on anticoagulation, suggesting that it's not a permanent stroke, but it's just a defect in blood supply to the brain locally.
If we can, looping back to a question or something you pointed out earlier, you talked about clotting in the veins and the arteries, and someone had, in their question mentioned that they get clotting in their arteries. What is the difference between the two, both in the impact on the individual and the treatment plan?
Yes, they're totally different. Veins, commonly a DVT or a leg vein, with swelling and things, that's perhaps one of the commonest, or in the arm. And they're not as life-threatening usually, although, for instance, you can get lung spread, sort of what's called a pulmonary embolism, and that can be a presentation. Now the arteries, different kettle of fish entirely. You can lose a leg, in severe cases, or get a heart attack, which is artery, or have a stroke, which is artery as well usually. So it just raises the worry and the danger of not treating. The statistics show that triple positivity, etc., high levels of antibody are the strongest link to artery disease, but we've seen patients with very minor changes on the tests who still had major artery problems.
So moving on to a different topic area. Right. And I know you've spoken that the two areas you're particularly passionate about, the brain we've just been talking about, and memory, and pregnancy, and we have some particular questions around menstruation.
Yes.
I would like to ask about Hughes syndrome and menstruation. I rarely have had periods, especially before diagnosis.
Yes.
I've only ever had some kind of regular periods on Warfarin and no contraception. Is there a link?
Yes, all aspects of pregnancy seem to be possible in Hughes syndrome. The commonest, of course, is 3 months miscarriage, an early miscarriage, repeatedly common. And the other ones are at the end of pregnancy, tragically, late pregnancy loss. And I remember the Times had an article once saying that that's the greatest tragedy known to man, that to lose a pregnancy at 8 months, especially if you've had 2 early pregnancy losses before. The third, and this one's much more ill understood, and that is infertility. The patient gets married, they try for a pregnancy for 1 to 2 years, nothing happens. And that can be a feature of Hughes syndrome. And a lot of clinics are now studying this to see whether, if one of those patients is positive for the tests, whether, for instance, heparin would help the results. And that's undergoing research now. Now, as far as menstruation is concerned, yes, a lot of patients do complain of menstrual abnormalities, which of course have different causes. One is pituitary and so on, but others local defect. If the patient's on a drug like Warfarin, of course, menstruation can be heavier, but normally it's not a thing that needs to stop the Warfarin.
That beautifully segues into the next question, which was related. I have very heavy menstrual bleeds. Is there a way to reduce it without increasing the dosage of blood thinner?
Yes, there is. There are medicines, there are hormone-based medicines now that are used for people with very heavy menstruation. It's part of gynecology and it's well recognized. So don't put up with that totally. It may well be something that can be treatable in a different way from dealing with the anticoagulant.
Right, on to a new topic area. and one that's going to test my elocution.
Okay.
I have APS Raynaud's, Dupuytren's contracture, and recently AF. And I'm now being investigated for MS, and I have peripheral neuropathy.
Mm.
Have I done all right so far?
Mm-hmm.
Okay,
Well
nice.
done.
I've mentioned to the neurologist that APS can mimic MS.
Yes.
So this is the core question. But he doesn't think so. Can APS mimic MS?
Oh, for sure. We published a number of papers, and others have published big papers looking at MS, especially atypical MS, where the features aren't quite right. Be suspicious of antiphospholipid syndrome there. It can totally mimic MS. And one of my patients years ago, she actually started a charity to raise awareness back 20 years ago, was in a wheelchair because of paralysis in the lower limbs. She didn't have MS, she had Hues syndrome, and luckily she had a clot, I think in her leg, but was treated with anticoagulants, and she's out of the wheelchair and walking normally now, simply because the blood flow had been insufficient, really. Now, the neurology of Hues syndrome can be anything. Patients can get nerves being hit, so it's a neuropathy, or they can get paralysis, like where it affects the spine. So there are different types. I would say, and I probably would say this, wouldn't I? But I think the antiphospholipid syndrome is a major neurological illness, and it deserves chapters in textbooks. I really do. It's so common that that's the presentation of the disease.
You mentioned earlier that you thought that over time it would be considered to be many more people have it than currently thought.
Yes.
And is that because you think that there are people right now who are misdiagnosed here?
I do.
Like the person you're just talking about.
I do. We see this. You just don't know how many are out there. There's recently I've been talking about the 1 in 5 story. There's quite a lot of literature now. It's becoming well known in research circles. The literature suggests that Hues syndrome is responsible for 1 in 5 cases of recurrent miscarriage, 1 in 5 cases of DVT or deep vein thrombosis, 1 in 5 cases of young strokes under 40. Now, if you look at young people getting a stroke, here's a treatable cause, a preventable cause, and some odd ones, epilepsy in teenagers, it's a common cause, 1 in 5. So if the various specialists dealing with those things start picking it up and referring it much more, we're going to see the numbers increasing rapidly.
We've had a question saying I have lupus and APS. The lupus has been reset. He or she has another further question, but I wanted to stop on what does that mean by reset?
I'm not sure. I suspect I guess it's going more into remission. Lupus is extremely fluctuating disease. When you're 20, it can be horrific. Normally, when you're 40, 45, normally the disease does settle down more. In fact, you can get off all drugs with lupus.
Okay, they went on to say it's now manageable after a stem cell transplant.
Oh, okay, now we're getting an answer. Yes.
So do you want to talk? Could you tell us a bit about the stem cell transplant?
Yes, I mean, a stem cell is an extreme form of treatment, as you can imagine, and
actually, I don't know. So what
stem cell is where you take some marrow from someone else, or it's on the basis that in an autoimmune disease, cells that have come from the marrow are not doing their job properly, and the result is that its autoimmunity stems from that problem. Stem cell treatment has been used now, as you know, for many years for patients with some horrible rare diseases where stem cells have proved successful. So, of course, it's been tried in lupus, and not many. In my lifetime, we have 2 or 3 cases. So it's not widely done.
So this is a particularly special, and I think the explanation might be I've had 2 extensive DVTs in 2018, which damaged the valves in my veins.
Oh, right.
So it might explain why they had the stem cell transplant. So the question was, is it possible to repair the valves? And does having APS then make it harder to repair them?
No, you can repair the valves. It's got much better than it used to be, the leg valves. Operations for varicose veins were pretty hit and miss in some cases, but I think that the whole subject has got much more successful. It's not my subject, the surgery of valves, but in the leg, but that's something that's quite possible, and the anticoagulation can go with it. Be careful around the time of surgery, etc., but it's quite possible.
Very, very interesting. And we had an interspersing with some nice messages. So, Professor Hughes, I met you in London along with my mother many years ago, and mentioned a chronic back problem that was only after walking for 5 minutes. And you told me to try aspirin. And after 3 weeks, I noticed an improvement. And after 4 weeks, that excruciating pain was gone and has never returned.
Fantastic.
I am only on 150 milligrams aspirin and wondered if you would recommend more aggressive anticoagulation.
Right. No, I wouldn't. I remember this patient actually.
No names.
No name. It's quite interesting. We've had a few patients that have had backache, commonest disease of mankind maybe, and they've had some nerve irritation. And when the diagnosis of Hues syndrome for any other reason has been made and aspirin started, the back pain has gone away, and it's probably because ischemia has just been the tipping point of the back pain to the nerves, and giving an aspirin makes the platelets flow better. But it's a very clear thing that we've seen in a few patients.
You said ischemia. What do you
Ischemia,
mean?
sorry. Ischemia is lack of blood, lack of oxygen.
Okay.
So it's ischemia that's
Yeah,
going.
no, thank you. And so what you're saying is that it was just enough to tip it, so it then had enough oxygen and blood, and therefore the pain went away.
Makes sense.
We've had. I'm going to try and bring in some of the questions from that we've had come in.
Right.
You are having a lot of ex-patients drop in and say nice things. Someone said they travelled from abroad, and you helped set their INR and massively helped them. I saw Professor Hughes a few years ago. I had a brilliantly insightful GP who just thought it was worth doing a few tests. My 17-year-old daughter has had a positive test for APS when she was 8, but the subsequent test at 10 was negative.
Right.
Should I have her retested now post-puberty?
It's a good question. Puberty seems to be the time when the troubles begin, in some cases, obviously a hormonal effect. So when you ask a patient, when did you first get symptoms? Well, when I was about 14, I had glandular fever and, different aches and pains. And in retrospect, that's when things probably started. So then I've forgotten the second part of the question, actually.
Should she be retested post-puberty?
No, if she's well and totally asymptomatic, watch for headaches. That's a common problem, but otherwise I don't think specifically. Anything that worries you about it, yes, be a nuisance, have her tested.
And APS Hues syndrome, there is a genetic component?
There is a genetic component. It's an autoimmune disease. Its basis is that the immune system messes up the clotting problem. And it's one of the first questions a doctor should ask. Do you have anyone in the family, female, with either lupus, MS, thyroid comes up a lot in your family, and it helps you make a diagnosis. So any patient of mine who says, I'm worried about my daughter, test.
Yeah. Okay. And why would it go from positive to negative?
Yeah, that happens. I mentioned earlier that some virus illnesses give you a temporary positive, actually, and normally, thank goodness, not associated with clotting. It seems to go away, and it may be that's what happened there, but it's negative, and that's important.
And in terms of testing on it, so can you have are there a lot of false positives? So is there a big downside to, in this case, having a test just to know?
Yes. The answer is there's no big downside. No, we always worry about this, that the worried well, or whatever the phrase is, need to test. And of course, it asks the question over the last 30 years, what happens to those people? And people are looking over 30 years now to see if they were correct to be worried about it. But luckily, it hasn't been a major issue.
And do you know what's the problem for that mother and daughter? What is the probability of if the mother has it of the daughter having it?
I can't give you the figure offhand, but it's small. I mean, you're talking about maybe twice as the background.
Okay, and the background is roughly.
It's varying from figure to figure now. I'll have to come back to you on that because they've updated figures. Background figures slowly increase as you recognize more people.
And actually, that's the sign of a true professional is that when they know the answer is changing, that they'll
Yes.
come back.
Yes.
And it is actually, you'd think it's a simple question. What's the background level of a disease? And it is not a simple question.
It's not a simple question. Take a migraine clinic. Test 100 of those women with migraine. You will find a percentage that's positive for sticky blood. We don't know that figure. There's no data yet. There's lots of research crying out to be done out there.
Yeah, and very, very important. So for those people could then have proper diagnosis that can help them. Right, moving on to some more specific questions. Then we'll bring in some more that have been posted right now. This one was picked partly because it's so complicated, and I think it asks a lot of questions here. I'd like to know the possibility of my definite SS anti-Ro positive turning to lupus.
Yes.
I've been so ill for months now. However, my anti-Ro has vanished on a test here, and inflammation markers went up. I take ibuprofen daily and turmeric too, which have affected it.
Well, this is
there's a lot there. So I have definite SS.
SS. Well, there's two things that could be: Sjögren's syndrome or scleroderma. It's difficult. SS, in my book, mostly Sjögren's syndrome, which is a cousin of lupus, if you like, a milder cousin that doesn't usually affect the kidney. And they
anti-Ro positive.
Anti-Ro positive. I was just trying to think of the dates. 1960s. There's a lot of research on the blood tests in lupus, and you look down a microscope, you see different patterns, and some of these were a waste of time, some of these were extremely important, and this one called anti-Ro is very important because it goes with a few things: sensitivity to drugs, quite a few important things, not least when you're pregnant. There's a very small chance of a baby having heart block. And as you probably know about that, a slow pulse. These things have got silly names, anti-Ro, R-O. Do you know why they got those names? They were named after patients. This is the one called anti-SM, for a patient called Smith. That's the way science worked. But those two have stuck.
Okay, and they.
I haven't answered that question fully, have I? Altering this Sjögren's, it can go away, the antibody. Often they're long-lasting, actually. The good news is that if you have that anti-Ro positivity, on the whole, you have a better prognosis.
Okay, so I think there's some interesting things learning there. But I think that particular person is quite complex and
Yeah,
probably
yeah.
requires them talk to their specific consultant. Someone talked about having angina attacks.
Yes.
And they said, I'm having angina attacks, but I don't have any other angina symptoms. I even went to A&E thinking it was a heart attack, which must have been a pretty frightening time. But fortunately came back okay. I have APS lupus. I'm on 80 milligrams of Claxine twice daily. Have not had rituximab infusion for nearly a year. Could there be any links for me and angina?
Yeah, the answer is yes. Angina is pain in the chest when the heart is unhappy. It's not getting enough blood flow. And it's something we see commonly in Hues syndrome. The cardiologists are now picking up on this, and it means that this lady, she sounds like she's been diagnosed with Hues syndrome, but needs a little bit of change in treatment monitoring. I'm absolutely sure that angina is associated, and she could be very much better if they got that right.
Okay, that's important. We had a question, a broader question, but it started with something very important. It said, I've been told I have APS due to tests following recurrent miscarriages, but have successfully had a family since, which
happens.
Which is obviously because there's treatment available due to your work. I wanted to mention that because I think it's important to focus on. And she went on to say, I'm not aware of any other ways in which APS has affected my health. But is there anything I should be aware of for my own health for the future?
Yeah.
And I thought that was a very important question about thinking about as life moves on, what she needs to think about. She's in her early 40s, no particular health concerns apart from, and you said it's another indicator, apart from regular monthly migraines.
Oh, well, that fits with the background of, I mean, we see a lot of patients who've been through pregnancy, had miscarriages, had treatment, a successful baby delivered in the end, and then discharged and not seen again for 20 years. On the whole, has it gone funny, the noise?
No,
sorry, I thought it was background. No, we see a lot of patients like that who've been through problems in pregnancy, treated, discharged, and not seen. And it's a worry because that patient could still get a clot at a future date. Now, the migraines, is she on aspirin would be my first question. And if she was my patient or my family, she would be on baby aspirin. And she would find that the frequency of the headaches would be decreased. And that might be all she needs at the moment.
Okay. So, but ongoing, are there, I think that's obviously some very useful advice. Ongoing, is there anything that that she should be looking out for in her own health that will help her?
Well, some of the things the patient can see or feel is memory, inappropriately bad, balance dodgy, headaches increasing in frequency, those three. And look at the peripheral circuit, look at your hands. Do you get cold circulation? That's another feature. From the history that she talks about, I don't think she needs any more aggressive treatment, simply to monitor and try aspirin.
I think that's very interesting, and so I think what you're saying is that she should keep an eye on the other symptoms, be aware of them to see if there are any changes happening. And in terms of aging with APS, is there anything that's likely to happen?
No, not likely, but higher risk. Yes.
What, for example?
Well, still people talk about the strength of the positive tests. If they're very strongly positive, you'd watch the patient more closely, more frequently.
And that's really, but so there's nothing particularly happening, so you're not going to
drop dead. You're not.
No. That's the extreme end of the bad outcomes of,
it's difficult to balance, isn't it, actually? But that patient's very definitely got the disease, she's at increased risk for a clot of some sort. And
Right.
if anything changes, I think get yourself
So I think your main focus is keep an eye on it, because what you want to do is make sure that you don't put yourself at risk of a clot.
Yeah,
and that's the main area.
That's right.
And actually, as people age, strokes do become more common. I understand it. So is there something that APS people need to be thinking about?
Definitely. You know, the whole syndrome can change, and the government have had a scheme for early diagnosis of stroke, but it didn't include testing for APL antibodies. So that's a thing for the future.
Especially when you're saying that with thrombosis, 1 in 5, you think
young people under 40.
Under 40, they have. I think it's obviously very important. So some questions from online. Can you ever get rid of APS?
Yes, it seems to go away in some patients, and the antibodies become negative. The patient feels well, and as far as you can make out, you have got rid of it. I think it's slightly worrying as a doctor that you'd rather not get rid of it. You'd rather see the patient on a regular basis, you know, twice a year, whatever.
So that you maintain that management.
I think so.
Now Graham's been doing a very good job also of keeping talking while I've been looking away at my screen to make sure that I've got the questions that have come in. So you've been doing that very well. I've collected them together now. So someone asked about extremely low folic acid levels. Is that common with APS?
No, it's not. It's a feature that we see in our rheumatology and in our hematology clinics. It's not specifically a feature of APS, though.
Is it? We had a question. Is it now your view that APS patients no longer benefit from therapeutic coagulation from anticoagulants who have never experienced a clot, yet display and experience all the other symptoms?
I mean, those patients. You mean with positive tests as well? I think,
yes, I think there's an assumption there. There's a positive test.
I mean, that patient is suffering from the disease, and I think that the treatment depends on the severity of the symptoms.
What does therapeutic coagulation mean?
It just means something to make the blood therapeutic treatment, and coagulation is clotting. So something to make the clotting less vicious or less positive, less risk.
Right. And I think you've spoken to that even if someone's not experienced, I think we actually just had a question where we were talking about it, even if someone's not actually experienced a clot, it may be, I think you were just talking about baby asprin in that case, that you would think that's something worth considering because of the risk of a stroke and that very dramatic impact. I wanted to. I think that. Also, we've had a few more questions that have come in, and we've had. I think we've had someone asking about if there's another option instead of Warfarin for someone who's APS positive and has lupus anticoagulant.
Yes, that's another way of testing for the same antibody. That's okay. It's a silly name, actually. It frightens people because they think they got lupus. And it was a historic name in the old days. They thought it was to do with lupus, but lupus anticoagulant is more to do with sticky blood. So,
right.
One of the confusions.
Okay, and so in terms of talking about, is there another anticoagulant? I think
we did cover that.
We've covered that,
actually. Yes, in a way, we're limited, aren't we, at the moment?
And so this is an interesting. So I've been diagnosed with APS, and I think this is going to be our last question. And I've got a couple of other things that people have sent in. I've had 18 DVTs.
Oh.
Like sometimes tested negative and sometimes positive for lupus. I have fibromyalgia and some other health problems. I've been on Fragmin for 10 years.
Wow.
And I can't tolerate Warfarin. is there anything different I should do for being tested positive for lupus? I think we might move it to lupus.
Yes. From the DVT's point of view, awful history, isn't it, actually? Normally a patient like that would... Oh, sorry, that's outside.
That's that. If anyone heard that, we are actually... Obviously, it's the perfect place to do a TV, to do a video. We're next door to a fire station.
Oh, really? Okay.
Actually, yes, but I think it's the headquarters.
So okay.
They don't send out so many.
Well, no, this poor lady. I mean, normally, of course, she'd be on warfarin for life, because so many DVTs. But if she says she can't tolerate it, I don't know quite what the reasons are that she can't tolerate. But there are, as we discussed early on, new anticoagulants. Maybe they're less than perfect in a serious disease like major strokes, but it may be a thing to look at in this lady if she cannot tolerate the warfarin.
And she mentioned fibromyalgia.
Yes.
And actually, we've had another question mentioning that as well. Can there be a link between?
Yes, fibromyalgia is a symptom basically. It's aches and pains, shoulders. I don't like the label because it doesn't help you the diagnosis. It just means in plain English you've got aches and pains. And a lot of our lupuses go through a history of fibromyalgia before they're diagnosed and treated with quinine, for instance. So I'm not surprised. I hear fibromyalgia mentioned 3 or 4 times in every clinic. Not to dismiss it, because it could be a feature presenting sign of a rheumatic disease.
That's fantastic. Now, look, we very generously given about an hour of this time. Yes. We've obviously overrun because you're very generous and keep answering questions, which is extremely kind of you. So to anyone whose questions weren't answered, I think we will put another date in the diary.
Definitely happy to do that. I'm happy to do that.
And so we'll get to some more then. But hopefully this has been a good start.
I hope I've answered some of your questions.
You definitely have. I wanted to read just because there is a bit of a fan club, so I wanted just to read a couple of the ones that have come in. And this was regards from South America, just saying thank you for your help to all the patients around the world.
Gosh.
And we have got people viewing from across the world. So I've definitely seen South America, I've seen North America, and Europe as well. So there's a lot of people from around the world watching. And I thought this one just summed it up very much, and I think was the right tone to end on. So I want to say thank you. And this person just said, thank you for your work, Doctor. I think your work has probably saved my life.
That's lovely.
Much appreciated.
Very, very.
Thank you. So, on that note, we'll say goodbye and thank you very much. And until next time, thank you everyone for watching. Obviously, GHIC is the Graham Hughes International Charity. It is focused on Hughes syndrome, APS. Looking to provide support, provide information, build awareness, and fund research. If you're so minded to, obviously, any donations or support or fundraising you feel able to do would be great. And if you go to the website, you'll see resources to do that. Thank you, everyone, for joining us. Thank you again, Graham, for joining and for answering so many questions and for all your time. With that, we'll say goodbye and thank you very much. Goodbye, and hope you'll be able to join us next time.